Okay, doctor, we are live. We can begin.
Good morning, good afternoon, good evening to all of you around the world. To my colleagues in India, uh, a late good evening as you are either celebrating or recovering from the results of uh, the elections. Today is World Schizophrenia Day, and what I'm hoping to do over the next 45 minutes or so is share with you some of the advances in the treatment of schizophrenia, what the current state of the art is, what's the best we can do at the present point of time, and some ideas about where we're going in the future with regards to more effective treatment of persons with schizophrenia. A little bit about myself. I've been a practicing psychiatrist now for almost 40 years. I had the privilege of going to medical school at the All India Institute of Medical Sciences. I did a residency at the National Institute of Mental Health Neurosciences in Bangalore before moving to the United States 35 years ago. And I've been researching schizophrenia uh, for over 30 years now, in addition to leading comprehensive treatment programs. I'm currently the professor and chair in the Department of Psychiatry at Western Michigan University. With regards to this presentation, I don't have any relevant financial conflicts of interest, but I would share with you that, as a clinician, I'm a doctor. I like seeing my patients get better, and I do everything and anything I can to see my patients get better. And sometimes, I need to remind myself that I need to re-examine what I'm doing to see if, in fact, my patient is benefiting. So I have a clinician's bias. I like information that's presented very simply. Give me hard facts. Don't give me speculation, because whatever information I get, I'm going to try and utilize it to help the next patient who walks in the door. And so that's my clinician bias. And as a researcher, I look for data. I look for information, hard data, not impressions or opinions. Now, one of the challenges with data, of course, is that if I pick and choose the data that I present to you, I can tell you almost any story I want to. So it's really important to look at all available data, critically appraise it, and then basically distill the information, all the available information, and present it in a very straightforward, simple manner that can be clinically applicable. So again, no financial conflicts, but my thinking is biased, if you will, or constrained by the fact that I'm a practicing physician and a researcher. Now, one of the things that comes with a long history of practice of medicine is that you learn that the practice of medicine is really quite simple at its core. Whether psychiatry or any other specialty in medicine, there are only three sets of facts that are really important in terms of helping any individual with a health condition. And the three elements in terms of helping people or treating people with any condition have to do with one needs to understand the condition that the individual is presenting with, know the disease that one is treating, how to diagnose it, how to identify it, understanding exactly what is wrong in what part of the body, because that is leading to the expression of this condition. How does this condition manifest itself? What will happen if you do nothing? What's the natural course, history of the illness? So that if you understand the condition that the person is presenting with, then in that case, you can identify specific treatment targets, exactly what you want to target, and define your treatment goals. What is it that you need to do and want to do, and with the patient in an effort to relieve his suffering or disability? So the first set of facts that one needs to know the disease that you're treating. A second set of facts that one needs to know is, so what tools do I have at my disposal? What are the treatments that are available? What do they do? Are they all equally effective? Do some work better than others? Do some treatments work for some aspects of the condition and other for other aspects of the condition? Do some treatments work in some patients and other treatments work in other patients? And can we tell before we try the treatments which patient is going to respond to what treatment? What are the side effects of these treatments? What are the and other costs of these treatments? So one needs to know the condition that one is treating, and thereby define treatment targets and goals. Know the treatments that one has at one's disposal, in how they compare, and then one needs to know how to use these treatments well, in the best possible manner to help each patient. And so how to use these tools, the principles of treatment. And in the context of psychiatry, I think one of the areas in which we could do better is we have a reasonable understanding, not a perfect understanding about the condition that we're treating. Our treatments are pretty good. I mean, they're not perfect. There are shortcomings, there are limitations, but we have pretty good treatments, pretty effective treatments. The thing that we can do better at is use these treatments more effectively to help each one of our patients. And I think the principles of treatment that we can apply: targeted treatment, measurement-based treatment, so that we can individualize treatment. And we'll discuss some of these issues in the course of this presentation. So 3 sets of facts. What do we know about schizophrenia? What we know about schizophrenia is a condition that has significant impact on the lives of individuals who have this condition. Less than 15% are fully employed and live independently. Once the condition begins, most people live the rest of their life with this condition. Only about 10 to 15% of individuals who have a first episode of schizophrenia don't have any of additional episodes. And so there's significant impairment in self-care, occupational function, social function, that is a result of this illness. This illness tends to start in late adolescence, early adulthood. That's when one has the first psychotic episode. And what we know about the nature of the illness, it's a chronic illness. It's a remitting and relapsing illness. And the remissions are generally incomplete, meaning that even when patients are doing well, they're not fully well. There are a number of different symptoms that persons present with. Schizophrenia presents with an admixture of positive symptoms: delusions, hallucinations, paranoia, etc. Negative symptoms: lack of social drive, lack of motivation, reduced ability to express emotion, etc. And cognitive symptoms: fairly broad impairment of a range of neurocognitive functions. So an admixture of different kinds of symptoms. And the illness tends towards chronicity and generally a poor outcome, although outcomes in persons with schizophrenia vary a lot. And that is one of the truths, the realities of this illness that we need to get our arms around. It's not one thing. It doesn't behave in exactly the same way across patients and in the same patient over time. There's extreme heterogeneity in the expression of symptoms in schizophrenia across patients over time, and a similar significant heterogeneity in course and outcome of the illness. So essentially, with this variation in schizophrenia, it's even more important to individualize treatment. So we talked about 2 critical aspects of the condition that are very relevant to more effectively managing it, more effectively helping people with the condition. One, there are different symptom dimensions. We talked about positive symptoms, negative symptoms, cognitive symptoms. One of the things that we've learned about schizophrenia in the last couple of decades is the fact that there are in fact distinct dimensions of schizophrenia, distinct symptom dimensions of schizophrenia, that essentially positive symptoms, negative symptoms, disorganization, cognitive deficits, mood symptoms, and motor symptoms represent six different aspects of the illness. There are different underlying brain circuits that are functioning abnormally that lead to these different symptom clusters. And what's even more important is the fact that our treatments affect these six symptom domains differently. So, for example, if you think about antipsychotic medications, the mainstay in the treatment of schizophrenia, what one finds is that antipsychotics are very effective in treating positive symptoms, that is, in terms of reducing delusions, hallucinations, paranoia, etc., and pretty effective in treating disorganization. But they don't do anything for negative symptoms and cognitive deficits. And with regard to mood symptoms and motor symptoms, they can both help and they can hurt. So antipsychotics can help depression. We use antipsychotics to treat depressions adjunctively with antidepressants. But antipsychotics can also cause depression, neuroleptic dysphoria. Motor symptoms, antipsychotics can be useful in treating catatonia, but they also tend to cause the worst kind of catatonia, neuroleptic malignant syndrome. So it's really important to keep in mind that when you're treating schizophrenia, it's not broadly, or is the person better, not better. It's really important to think about what is better and what is not better, or what may be getting worse as something else is getting better. It's really important to keep track of these six different domains or six different dimensions of schizophrenia separately in each patient as we try and help the individual function better, do better in the context of this illness. So one very important fact, six different dimensions with different underlying pathophysiology and a different pattern of response to treatment. So that's one fact about schizophrenia that is really important to keep in mind as one thinks about, well, how can I best help this person with schizophrenia? A second fact about schizophrenia that is really important to keep in mind is that there is a certain natural history of schizophrenia. It's not identical in all patients, but it's important to keep in mind that this is the natural trajectory of the illness. So although the first psychotic episode begins in late adolescence, early adulthood, in this graphic, it's illustrated between the ages of 20 and 25, but that's late adolescence, early adulthood. Little later in women, that's when schizophrenia, the first psychotic episode tends to begin. But persons who go on to develop schizophrenia have had difficulties from early childhood. So there is significant premorbid dysfunction. Persons who go on to develop schizophrenia later on in life as little kids are shy, don't play as well with their peers, tend to have difficulties academically. Although these are pretty non-specific, and people who don't, there's nothing like schizophrenia that they experience later in their lives can also show that. So it's very non-specific, but you have premorbid dysfunction. And then about 3 to 5 years before the first psychotic episode, if you will, when you diagnose schizophrenia, when you can diagnose schizophrenia, you have what's known as the prodrome. About on average now, 3 to 5 years before the illness begins, you have some soft cognitive impairments, some difficulty paying attention, some anxiety, some reduction in motivation. Then about 2 to 3 years prior to the onset of the psychosis, you have mood symptoms, depression, cognitive symptoms getting a little worse, negative symptoms getting a little worse. And on average, about 1 year before the first onset of psychosis, when you can diagnose schizophrenia, you have soft psychotic symptoms, or what we call attenuated psychotic symptoms. And then you have the onset of the illness. And in different countries, the time between the onset of the illness and the initiation of treatment varies. So, for example, in America, in the United States, the average gap is about 15 to 18 months between between the onset of psychosis and initiation of treatment. In India, it varies across different settings, if you will. It can be, but the average in India too is about the same, although the variation there is much greater. So this is, and why is this an important fact to keep in mind? Because, as we remember, schizophrenia is a remitting and relapsing illness. And the longer time that patients go between onset and initiation of treatment, the worse their illness gets. Psychosis is toxic to the brain, and there are brain changes that occur with untreated psychosis. And you see that with relapses. Why is relapse prevention important? Because with each relapse, when a person is acutely psychotic, they're obviously distressed, they're not doing very well. But there's also an increased risk of suicide and violent behavior when they're acutely psychotic. Obviously, it causes significant disruption in their lives, employment, education, otherwise socially. So bad things happen when you're acutely psychotic, either in the untreated phase initially, and then with each relapse. But there's something else that happens with each relapse that is even worse. Each relapse has long-term consequences. With each relapse, the subsequent recovery is less complete. The remission takes longer to achieve. The same treatment that was effective before the relapse may no longer be effective after the relapse. You need to use higher doses, different medicines, etc. And regaining prior function level is more difficult. So critical. What are we trying to do when we're trying to help people with schizophrenia? So we talked about the first set of facts. What's the nature of the condition? What is wrong? Because we want to define our goals and define treatment targets. So essentially, ultimately, our goal is really to help the patient lead the most meaningful, productive life that they can. And in an effort to do that, short term, when they're acutely psychotic, we want to make sure that they remain safe because there's an increased risk of violence, suicide, etc. They can do hurtful things when they're acutely psychotic, and reduce the symptoms, treat the acute symptoms rapidly. Long term, our objectives are prevent relapses. Very important to prevent relapses. Treat comorbid syndromes like depression, anxiety, substance use disorders, etc. And minimize, to the extent possible, the side effects of the medication. So ultimately, clearly, the objective is to improve the function and optimize the quality of life of the individual. So we've got some understanding of the nature of the disease, schizophrenia, so that we've now defined treatment targets and goals of treatment. Now, in terms of the biology of the illness, we've got a much better understanding of the neurobiological underpinnings of schizophrenia, but we've still not defined a specific lesion, if you will, or the means to correct that specific lesion. So from a biological perspective, our treatments are driven more by clinical trials. Do they work? Do they not work? Rather than a succinct understanding of what the biological abnormality is in an effort to correct the abnormality. But we're getting there, and we'll come to that towards the end of the talk when we talk about the future in the treatment of schizophrenia, future developments. So first set of facts, know the disease. And we've tried to understand what we know currently about the nature of schizophrenia and to define these treatment targets. What about its treatment? The second set of facts that we need to know are what treatments do we have at our disposal and how do they compare? What do they do? So, the pharmacological treatment of schizophrenia, antipsychotics are the mainstay. And there are about 67 antipsychotics available in the world. In the United States, we have 20 antipsychotics available. In India, you have access to almost 40 different antipsychotic medications. But antipsychotics are the mainstay. And what do these antipsychotics do? Well, they don't work equally well on the 6 different dimensions as we discussed. They work pretty well for positive symptoms and disorganizations. They don't do much for negative symptoms and cognitive symptoms. And they can both help and hurt the mood symptom domain and the motor symptom domain. But there are 2 very important things that antipsychotics do, and they're different things. And both are very important. Antipsychotics treat the acute episode, they reduce symptoms, they treat psychosis. But there's another thing that antipsychotics do that is at least as important, if not more so. Recall that schizophrenia is a remitting, relapsing illness. And each relapse is bad, both because of its short-term and long-term implications. And antipsychotics are very effective in very significantly reducing the risk of relapse. They reduce the risk of relapse by almost 70%. So 2 different things, 2 very important things that antipsychotics are effective at: treatment of acute psychosis and prevention of relapse. So these are the 20 antipsychotics that we have in the United States. In India, as I mentioned, you have almost all of these and many others as well. But broadly speaking, the antipsychotics we classify into so-called typical antipsychotics, first generation antipsychotics, neuroleptics, which you see on the left side of your screen, chlorpromazine being the first, and then you have a listing in the second column. And then you have, and the second kind of antipsychotic, if you will, are the newer antipsychotics, what we call second generation or atypical antipsychotics. And essentially, clozapine was the first of these. And then you've got a whole slew of others that have been developed since. So what do we know about these antipsychotics? Well, this is what we know, that with regards to psychotic symptoms, all antipsychotics are about equally effective. Clozapine is different. Clozapine clearly works in about half the patients who do not respond to other antipsychotics. Clozapine works in about half of those patients with regards to the positive symptoms or psychotic symptoms. But the others are about equally effective in treating psychosis. Now, having said that, some antipsychotics are easier to dose than others. So in terms of actual clinical practice, it might appear that some, like olanzapine, for example, are more effective because it's an easier medication to dose and utilize, if you will, than some other medications. But if you are able to utilize them optimally, they're about equally effective. Clozapine is different, more effective in otherwise refractory patients. The atypical antipsychotics have a much lower risk of causing EPS, and on average, a somewhat higher risk of causing metabolic side effects than the typical antipsychotics or the older antipsychotics. Having said that, it's very, very, very important to recognize that within the group of so-called typical antipsychotics, as also within the group of so-called atypical antipsychotics, there's a lot of variation. Even amongst the atypicals, there are some medications that have a higher risk of EPS and some that have a very, very, very low risk. Similarly, amongst the atypicals, there are some agents that have a really, really high risk of metabolic side effects and others that have a negligible or really very low risk comparable to the typical. So lot of variation in both groups, but on average, that's what we can say about typicals and atypicals. Now, knowing that an antipsychotic is a typical or an atypical is not enough, because each medication has unique side effects. It has very unique pharmacokinetics, drug-drug interactions, etc., which are relevant to how best to use it. And very importantly, different patients respond differently to different medications. So there's a lot of variation in terms of response. And it's really important to recognize that you want to optimize the effectiveness. And to optimize effectiveness, you want to maximize the efficacy. Use them in ways, doses that basically help control the psychosis, the positive symptoms and disorganization to the maximum possible extent, and minimize the side effects of the medication. And you've got a listing of some of them. Now, extrapyramidal side effects or Parkinsonian side effects are really important to keep in mind. You really want to prevent them. When you're using an antipsychotic, very important, get the therapeutic effect you want without EPS, without the need to use an anticholinergic. Because if you're able to do that, the risk of tardive dyskinesia, it decreases substantially. So the risk of tardive dyskinesia, if you're able to use an antipsychotic in such a way that you get a robust antipsychotic effect without EPS, without having used an anticholinergic, the risk of tardive dyskinesia is decreased almost 80 to 90%. So very important. Good antipsychotic effect, no EPS, no anticholinergic use. It doesn't matter whether you're talking about a typical or an atypical antipsychotic. That's what you want to do. Another advantage is if you're able to get a robust antipsychotic effect without EPS, negative symptoms are better, cognition is better, depression is better. And so, very important, when we're using an antipsychotic, meticulously avoid EPS and avoid long-term use of anticholinergics, because then these advantages of so-called atypical antipsychotics go away. And it's important to keep in mind that ultimately it's the effect that you're getting using an antipsychotic in a patient that's important. That is, I'm using an antipsychotic, typical or atypical. I really want to control the delusions, hallucinations, get rid of them if I can. So I want to get a robust antipsychotic effect, but I don't want akinesia. I don't want akathisia. I don't want other EPS, because if I get them in my patient, I might be able to use an anticholinergic short term, but long term, bad things are going to happen to my patient in terms of loss of the benefits that you see here. So avoiding EPS is very, very important. And given the fact that there is so much variation in terms of response, it's critical to individualize treatment. So we've talked about, the nature of the condition, the first set of facts we need to know. We've discussed the second set of facts that we need to better appreciate, what treatments we have and how they compare. And now, how do we best use these antipsychotics? And critical here, these are three aspects that are critical in terms of using them optimally: targeted treatment, measurement-based treatment, so that we can individualize and individually optimize treatment. And so essentially, as we think about targeted treatment, we've got to define targets. So in different patients, there may be more severe positive symptoms or more severe symptoms of a particular domain. We've got to define what the treatment targets are in each patient. And then we need to measure what's happening to those treatment targets in the course of treatment. Are they getting better or not? And so define the targets with the patient and then monitor the impact of your treatment on those targets. And one of the things we've often said in psychiatry is, but we don't have any blood pressure instruments. We don't have any blood tests or x-rays that we can use to monitor our patients as we're treating them. And the fact of the matter is that we do have tools. We've got some pretty good rating scales, if you will. Now, it's true that some of these rating scales take some time to administer. But in the context of schizophrenia, there is a very, very, very simple rating scale. It's in DSM-5. It's in section 3 of DSM-5. Very simple 8-item scale, with each item being rated on a 0 to 5 scale. We'll see that shortly. Very simple scale. It takes about 2 to 3 minutes, if you will, in addition to whatever your usual clinical interview with the patient. It takes a very short time, but it provides very valuable information. So ongoing monitoring is critical, because one of the things that I don't know to what extent you experience it in your practice, but in my practice, one of the challenges is the patient doesn't seem to be getting better, or seems to be getting a little better, but not fully better. And there's a temptation to add another antipsychotic. And by the time I'm a little more comfortable, the person might be on 4 or 5 different agents, if you will, including multiple antipsychotics. If, in fact, I'm monitoring what's happening to my patient and seeing what items or what dimensions are getting better and which ones are not, I might be able to more rationally utilize the medications and optimize treatment for that individual. So it's really valuable from that perspective. The other thing to monitor on an ongoing basis is the side effects. And there are a number of protocols that are available for monitoring side effects, but obviously they have to be individualized, with regards to the patient. So this is the simple instrument in DSM-5. 8 items, as you can see. The first 2 items, hallucinations, delusions. The first 2 items, hallucinations, delusions, are positive symptoms. And then you've got 1 item in disorganization. You've got 1 item motor symptoms, catatonia. You've got negative symptoms, cognition. And then you've got 2 items for mood, because depression and mania have to be measured separately. So 8 items, and you can see all the 6 domains are being measured. And each item is rated on a 0 to 4 scale. So 5 points, if you will. 0, that is clearly not present. 2 to 4, that item is clearly, that hallucinations, for example, is clearly present. 1, I can't tell whether it's present or absent. It's almost a hallucination, but not quite. And so equivocal, if you will. But 0, clearly absent. 1, I can't really tell, definitely. And 2 to 4, clearly present. 2, clearly present but mild. 3, clearly present but moderate. 4, clearly present and severe. And so you're probably thinking, oh, this is okay, but isn't this somewhat vague, somewhat arbitrary? Actually, if you look at DSM-5 and Section 3 in DSM-5, what you will find is actually each of these scores for each of the 8 items, what 0 means, 1 means, 2 means, is specified. There are anchors for each of those. And what is even more important is once you begin using this instrument, you will find becoming more and more comfortable and developing reliability with regards to yourself, with regard to use of this instrument. And so, and you'll find it incredibly valuable. In the interest of time, I'm not going to be able to kind of give you a number of clinical vignettes in terms of how these measurements are going to help you in terms of each one of your patients. But I can share with you that there are a number of clinical circumstances in which having these measures has helped me decide, do I want to add an antidepressant at this time or not? Do I want to change the antipsychotic or not? So again, having specific scores on those 6 domains in this particular patient in the context of treatment is the same thing as, is the blood pressure getting better or not? What is happening to urinary output? What is happening? So when you're treating medical conditions, non-psychiatric medical conditions, you're monitoring different targets and what's happening to different targets. It's the same thing with regards to treatment of schizophrenia with antipsychotics, monitoring these different with any with medications, monitoring these different targets and seeing what's happening in this patient in the context of your treatment will help you individualize treatment. So bottom line, monitor both if the treatment is working or not working, and basically make adjustments, based on what you're seeing. So in terms of goals, again, going back to what we were trying to do, both short term and long term, we have, uh, uh, short term acute treatment, reduce symptoms, make sure the patient stays safe. Long term, prevent relapses once the patient is a little better, stabilized, prevent relapses, treat comorbid syndromes like depression, anxiety, etc., minimize other side effects. And the bottom line here is, if this is something that I find very useful in my discussions with my patients. That is, what do we, you've come to see me, or you've been brought by your family to see me because you're not doing well, and how can I best help you? And so on the right of this particular graphic is what the patient wants and what the patient's family wants. The patient family and the patient says, I want to live a normal life. Really, what does the patient want? The patient wants exactly what you and I want in terms of our lives. A life that's productive, meaningful, healthy, uh, without pain, suffering, if you will. And so that's what the patient wants. And that's what you see on the right. And the aspects listed below it are the areas in which you want to optimize functioning, optimize quality of life, if you will, for the individual. So that's what the patient wants. On the left is what we can do. What do we offer as specialists, as psychiatrists? Well, we provide treatment. And we can provide access to rehabilitation, and we can connect patients with necessary supports around them that can be helpful to them. Ultimately, what we're trying to do, one of the first conversations I have with my patients is, once I've understood what they want, once I've done a diagnostic evaluation, well, when they say, well, doctor, why am I not able to do what I want to do in my life? Well, because you have schizophrenia. So what we're going to try and do is reduce the impact of this condition on your life, eliminate it if we can, but certainly try to reduce it. In other words, our objective collectively is to reduce the burden of schizophrenia, reduce the disease burden. But we need to recognize that whatever we do can add a treatment burden, side effects being a big part of it, but there are other treatment burdens that we can add, if you will. So getting back to uh, uh, what we can do, we provide treatment to reduce disease burden. Antipsychotics are a big part of it, if you will. Uh, uh, Cognitive behavior therapy might be another treatment that we might employ to reduce symptoms. But antipsychotics and other medications, big part of reducing the symptoms and preventing relapses. Rehabilitation refers to efforts to help the person work around their deficits. That is, we are not completely eliminating the expression of the illness, and we're not completely eliminating symptoms, but we're helping the person to develop skills that enable them to function even with those deficits. It's like physiotherapy, if you will, that we utilize in the case of musculoskeletal injuries. And in the context of schizophrenia, social skills training is one such modality that's helpful. And the third thing that we try and do with the patient is help provide supports around them, things like supportive housing, supported employment, etc. Manipulate the environment around them that will enable them or facilitate better level of functioning. So we try to reduce the disease burden by treatment, rehabilitation, and providing supports, while recognizing that we may be adding side effects. So what we really try to do is maximize the reduction of disease burden while adding as little treatment burden as possible. So in terms of antipsychotic therapy, how best to optimize it? Well, we need to have the three keys to optimizing antipsychotic treatment. What's the sequencing? What antipsychotic should I select first? And how do I utilize them in sequence? How do I dose them? Dosing is key. And how long do I try different treatments for? And what's optimal is about a 6-week trial of an antipsychotic with optimal dosing, 6 to 8 weeks. In the real world, we don't have the luxury for longer trials, 10 week, 12 weeks, if you will. So a 6-week trial, if you see nothing in the first 2 weeks, then, with good dosing, then that might suggest a lower likelihood of response. So start with a systematic 6 to 10 week, 8-week trial of one antipsychotic and really paying attention to dosing. If that doesn't work, try another agent in the same way. And if that agent doesn't work, get to clozapine. So don't use clozapine as the 40th antipsychotic or the last antipsychotic available to you. If a couple of antipsychotic trials, good dosing, good duration, have failed, then think about clozapine early, because clozapine is the only medication that's clearly been shown to work in about half the patients who've not responded, whose positive symptoms, whose delusions, hallucinations have not responded. Clozapine, if you've got a patient whose psychosis, whose delusions, hallucinations have gotten better, but who has severe negative symptoms, clozapine probably is not going to do anything there either. So the critical thing is for antipsychotic refractory positive symptoms, use clozapine early or use a long-acting agent, because non-adherence is often a factor in terms of persons not doing well. And then, other strategies should come after that. So those are some keys. And this is the guideline that we utilize in our practice, if you will, in terms of the sequencing of treatment. And this is what I would strongly recommend you consider in your practice. In terms of some things we can do today to optimize the effectiveness of our treatments, one, as I mentioned, targeted treatment, measurement-based treatment, and essentially make rational adjustments to treatment. But some specific guidelines, suggestions that I would make, untreated psychosis is costly. And so minimize the duration of untreated psychosis at the outset of the illness. Prevent relapses. Acute improvement is very important, but then relapse prevention is very, very important. Early recognition and effective early intervention important. Psychosocial interventions are very useful, very important. And so we are paying less and less attention to those. Those are very important. Medication adherence is a challenge, and we don't tend to utilize long-acting agents as much as may be appropriate. And minimize the use of these so-called side effect medications, anticholinergics. Don't use them long-term. They really hurt patients. Benzodiazepines long-term use, there are very few patients. There are some who may benefit from long-term use, but they're very, very small. And clozapine should be considered earlier than we do at the present point in time. Now, having said all that I have about, how best to use the treatments we have effectively, how to optimize treatment at the present point in time, it's important to recognize that we have limitations in terms of how antipsychotics work, the ones that we have available. They don't work for all domains, as I mentioned earlier. They don't work very well for negative symptoms and cognition. And the other thing that we've recognized is that, I'm sorry, I don't know what's going on with the slide. I've lost control of the slides, but that's okay. I can go on without the slides, if you will. So essentially, in terms of, yeah, okay, thank you. Sorry for the interruption. In terms of the antipsychotics we have, they don't work for negative symptoms, cognitive symptoms. And another big problem we have is that the person who presents to us with schizophrenia has been ill for the first time, has been ill for some time. So there's a duration of untreated psychosis in which there's been deterioration. The brain has basically deteriorated, ventricular enlargement, loss of certain cortical structures. Essentially, with that deterioration is very difficult to reverse. We can prevent future episodes effectively with the treatments we have, but we have to intervene earlier than we have been thus far. So the medications are not completely effective, and we need to be intervening early. And of course, the medications we have are associated with a range of adverse effects. So if one thinks about schizophrenia, and recognizing that the decline in schizophrenia occurs at multiple time points, and each of these time points represents an opportunity for us to make a difference. So this is a person cruising along, but in schizophrenia, the fall occurs at multiple time points. And one of the major changes, major advances in the last several years, really, has been our ability to identify those at very high risk for developing schizophrenia about a year or so on average before the onset of psychosis, what we call persons with attenuated psychosis syndrome. So these are individuals who, it can be at any age in life, but it's typically in the adolescent years or very early adulthood. And these are individuals who show soft psychotic symptoms. And essentially, there are very specific criteria, which I don't have the time to kind of, discuss in detail. You might want to read the relevant chapter in DSM-5. I will acknowledge, by the way, a conflict here. I was one of the people who worked on DSM-5. I was in the DSM-5 work group on psychotic disorders. But take a look at that because they're very specific criteria. And what's important to recognize is if you identify individuals with attenuated psychosis syndrome, about a third of them go on to develop psychosis. Now, let me put that in context of what that really means. The incidence of schizophrenia is about 15 per 100,000, 15 to 40 per 100,000 per year. Now, these individuals are about 300 to 500 times more likely to develop schizophrenia in the next year. So the risk of conversion to psychosis, about 2/3 of that is schizophrenia. So these are individuals at 300 to 500 fold, 300 to 500 times more likely than a person in the general population to develop schizophrenia in the next year. And this is the really important thing to keep in mind. Now, obviously, 2/3 of these individuals will not develop schizophrenia. About a third actually will, quote, be diagnosed as psychiatrically healthy at the end of the year. So it's not that all of them are going to develop, a majority actually will not develop schizophrenia, but individuals in this group are 300 to 500 times more likely than the general population to develop schizophrenia in the next year. So what should we do? Well, we need to be able to identify these individuals. Do not routinely use antipsychotics. One of the challenges, problems in our thinking about schizophrenia has been that we think antipsychotics work at every stage of schizophrenia equally well. Not true. And it's really important to recognize that schizophrenia has distinct pathophysiologies at different stages of the illness. So, in the context of attenuated psychosis syndrome, do not routinely use antipsychotics. Monitor the person very closely so that if and when they convert to psychosis, they become psychotic, you can intervene immediately so that the duration of untreated psychosis is minimized. Treat the comorbidities. About three-quarters of these individuals will have depression, significant depression, or anxiety, or substance use disorders. And so treat them effectively because you'll significantly help them. Looking ahead, there are new molecular targets that are being developed in schizophrenia. Phase-specific treatments are being developed. That is, in different stages of schizophrenia, use different treatments. Better pharmacogenetic strategies to better individualize treatment are being developed. Rational combinations of medications are being developed. And in terms of new treatment targets, if you look at all the treatments being developed in psychiatry, there are about 120 different molecules that are being looked at in psychiatry. Schizophrenia, the 36 of these molecules are being developed for schizophrenia. And as you can see, there are different stages of development. With that, let me stop and see if there are any questions, concerns, issues that you might have. That we have about 8 minutes for questions. So please go ahead with any questions that you might have. I am not seeing or hearing any questions. And given that, let me actually suggest a couple of, as you absorb the presentation, if you will, I think it'd be useful for you to take a closer look at the slide set. And I'd be happy to kind of take any questions that might come up even offline later. But I think the bottom line is, we have a much better understanding of the nature of schizophrenia today and what we need to try and do to help persons with this condition, both short term and over the long haul, if you will. We have tools that we have are not perfect. The medications we have are not perfect, but they're pretty good. They're pretty effective. They're pretty good. And I think we have a much better understanding of how to use them effectively. And so I think the bottom line that I would like to convey to all of us is we can do better. We can treat persons with schizophrenia more effectively by specifically targeted treatment, by defining specific targets, and then measuring the impact of our treatments on those targets to see if they're effective or not, and making appropriate adjustments in the context of treatment. Because that is the only way today that we can really individualize treatment, and we can try and do the best we can for each individual with this condition. With that, I'd like to wish all of you a good evening, good night, and best of luck with your practices. Thank you for all the good work that you do as we all collectively try and help people with schizophrenia lead better, more productive, more meaningful lives. Thank you again. Good night.
Doctor, there are questions in the link that I provided.
I don't see any.
Doctor, just refresh that link, please.
refresh that link. Okay. Oh, I see. So Dr. Ravi from Delhi asks me, based on your clinical experience, which antipsychotic do you think is least likely to cause EPS? And what I would say to you is, in terms of EPS, what we know is clozapine is the least likely to cause EPS. Quetiapine, uh, also very low risk of EPS. And then there's a variation, if you will. So EPS very important, but you've got to be mindful of making sure that you're getting the efficacy you want, and you've got to pay attention to other side effects as well. Dr. Amol from Aurangabad asks, which are the most effective steps that can be taken to manage adverse effects associated with clozapine? And the key is which adverse effects. So that depending on what the adverse effect is, you will have different strategies. I can refer you to an article that we wrote about a year ago on this particular topic, in which we discussed different side effects. So, for example, if you're thinking of hypersalivation or drooling that you see in about 40 to 50% of persons who are on clozapine, there you can use glycopyrrolate, for example. This is an anticholinergic agent that does not penetrate the blood-brain barrier. And so that's available orally. Or you can use cogentin at night, if you will, because that's when the drooling becomes most problematic. So again, getting back to the question itself of managing side effects with clozapine, essentially, depends on what side effect it is. Dr. Neeraj from Amritsar asks, what are the most important advantages of long-acting injectable antipsychotics, LAIs? And so the main advantage of long-acting injectables is a better handle on adherence, if you will. Are they actually taking the medications or not? And so you've got a much better handle on that. But the other advantage of long-acting injectables is actually the variation in blood levels is less than you see with oral antipsychotics. And that is important because that enables, it's the peak blood level that relates to side effects. And it's the trough blood level that relates to efficacy. And so if you can reduce that variation, as you can get with long-acting agents, you can reduce side effects, if you will. Which rating scale is the most useful in assessing? Dr. Bhavesh from Ahmedabad asks, which rating scale is the most useful in assessing the efficacy of antipsychotic drugs in clinical practice? And as I mentioned, I mean, there are a number of scales, but if you want to be efficient with your time, the scale that I would recommend would be the DSM-5 scale. And again, I don't get any money for anyone using the scale, by the way. The people who work on DSM-5 have no financial benefits from DSM-5, but it's a scale, it's free to use. It's in the section 3 of DSM-5, and I would strongly recommend that you consider using it. And if you need more guidance in terms of how to better use it, etc., I think, connect with me offline. Dr. Preeti from Bangalore asks, of the molecules under development, which do you think is most promising in the management of patients with schizophrenia? I cannot make any predictions, Dr. Preeti, because a number of agents that we've tried have not developed. Glutamatergic strategies appear to be most interesting, if you will, at the present point in time, but there have been a number of failures. So I'm still very hopeful, but I can't give you a leading horse yet, if you will. Dr. Vishal from Madurai asks, what are the most effective steps that can be taken to improve adherence to antipsychotics? And essentially, long-acting injectable medications are one of them. There are some new gadgets that allow better awareness, better tracking of adherence. But I would suggest just, providing cues to the patient, essentially simplifying medication regimen, really depending on how uh, well functioning the person is, really reminding the person about why they're taking the antipsychotic, what the benefit is to them in their language, if you will, in their terms. I mean, I get treatment for high blood pressure. And although I'm a physician, I know the bad things that can happen to me if my blood pressure is not controlled. Even I struggle with that, if you will. Dr. Gautam from Bhopal asks which antipsychotics are most appropriate in patients with comorbid diabetes. And so, again, if you've got comorbid diabetes, the most important thing that I would recommend is A, treat both the schizophrenia and the diabetes effectively. B, monitor both, if you will. There are now, in terms of which antipsychotics have less of a deleterious effect or harmful effect with regard to diabetes. There are a whole range of agents that, such as lurasidone, such as uh, uh, brexpiprazole, aripiprazole, ziprasidone, etc. So a lot of the owns, if you will, the things that end in own, are uh, generally better with regard to metabolic side effects than what we call the enes, like quetiapine, clozapine, etc., olanzapine, etc., which have more of a deleterious effect metabolically. But again, the key really is to monitor both most effectively. And, if you can, use antipsychotics that have less of a deleterious effect on diabetes. Dr. Akhil from Cochin asks, do you think brexpiprazole scores significantly over aripiprazole? Well, they're more similar than different, but they are different. And so pharmacologically, they're different. Clinically, in terms of brexpiprazole versus aripiprazole, I think the major thing there might be that with brexpiprazole, there is a lower risk of akathisia than aripiprazole, and so that's something to. And there are now other what are the disadvantages? It's we're still learning more and more about brexpiprazole as we continue to use it. It's relatively new, so we're learning more about it. But the major difference appears to be at this time a lower risk of akathisia with brexpiprazole. Now, bear in mind, how is brexpiprazole different from aripiprazole? A number of pharmacological attributes where it's different. And so it's a different kind of partial agonist to, but again, we just wrote a paper reviewing brexpiprazole that I would recommend to you, in which the differences between brexpiprazole and aripiprazole are discussed in detail. It's a paper which one of my junior faculty members, Don Brunzil, was the principal author on. It's a Brunzil and Tandon paper from a couple of years ago. There are a couple of questions on loracidone, both asked by Dr. Monica Sharma from Agra and Dr. Ishwarya from Thanjavur about loracidone. And loracidone, it's a very effective medication. It's it's a little difficult to use in terms of schizophrenia because its absorption is based on food or not. So if you take it on an empty stomach, basically you have you're getting half the loracidone you are as compared to when you're taking it on a stomach in which you've eaten 350 or more calories, if you will. So food makes a big difference to its absorption. So people have underdosed it in schizophrenia, if you will. And so you need to use higher doses, very effective medication, but more effective than any of the others? No. I mean, as I mentioned earlier, they're about equally effective if you use them optimally. And Dr. Priyanka Jo from Thane asks, can you tell us about effective and rational combinations of antipsychotics that can be used? I think the critical thing is make sure that you're using the sequence, you're using antipsychotics in the optimal dose giving them enough time to see if they're working or not, and make sure that you use clozapine before you get into combinations of antipsychotics or a long-acting injectable before you get into a combination of antipsychotics, because those are much more evidence-based, if you will. Now, once you've tried clozapine, it's not worked, or you can't use it for whatever reason, or you've tried long-acting injectables and that's really not accomplished much, then when you get to combinations, there are relatively few combinations that have some basis, some clinical data that supports their effectiveness. One of them is, so if you've got a person who's got somewhat better with clozapine, but not fully improved, then adding a little bit of an agent like aripiprazole or risperidone can be helpful. Very low dose, to up to 2 milligrams of risperidone per day, or up to 5 to 10 milligrams of aripiprazole per day. So very low dose in terms of that combination. There are other combinations, but I think the critical thing to keep in mind is before you get to the combinations, do give clozapine a try, and do give active consideration long-acting injectable before you get there. Because the one thing I can tell you is once you begin using uh, uh, combinations, it's very difficult to stop them because patients can get worse. And Dr. Nagaraju from Visakhapatnam asked me, what are newer drugs available to treat schizophrenia? And with regard to, there are a whole range of drugs that are in development. But at the present point in time, the newest drugs we had were brexpiprazole and cariprazine, which are both dopamine partial agonists like aripiprazole, but they're different in terms of the partial agonist attributes. Uh, I'm sorry we've run out of time, and I know it's late night in India. So I just want to thank all of you for your attention and wish you the very best. Take care. Thank you.